This conference will now be recorded.
Excellent. And I'm going to call out who I see. So I see Jake, Willie Bermudez, Dave Sanders, Dennis Correa, Carl Foreman, Rich Jackson, John Appler, Les Shelderup, Professor Bill Burhans, Paul Frieda, and we've got a caller that just arrived. Who's that on the telephone?
Sylvester.
Hello,
Everybody.
Sylvester.
How's it going?
Hello, Sylvester. All right, so did I catch everybody? Guess so. There's nobody squealing. All right. So Dave, we've got a couple of people that are, well, one person who's new to the call, Willie Bermudez, who I introduced briefly before, but Willie is a good friend of Bill Franklin's, and as Willie pointed out, they served together in the forces. And belated Happy Veterans Day, Mr. Bermudez, to you. Willie has very generously offered to work with us to provide Spanish-speaking support to any man that might need it. Willie will talk a little bit about his background. He, thank God, did not have advanced disease. He had high intermediate and seems to be doing well, but he'll tell us just a little bit about that. But I've invited Willie to listen into any and all calls to the extent that, you know, we could find Spanish-speaking men that have metastasized disease and may need some help and some guidance. So Willie will pick up a little bit. He'll also hear how we run these calls, which is very helpful. And in the long run, I would love to be able to offer a Spanish-speaking group, and that's where we hope. But we're going to see how we do just with some one-on-one to begin with. So, if you have Spanish-speaking friends, if you live in areas where there's a large Hispanic population, and somebody needs some support, some prostate cancer support, we're now in a position to afford that. I'm very pleased to say. Then Dave Sanders, you mentioned that you were with us 2 or 3 years ago. Is that right?
Yes. Well, I'd just been diagnosed and had a PIRADS 5 from an MRI, and long story short, went in for a focal laser ablation. And went in with a PSA of 8, came out with a 1, so that felt good. And I remember you and not a lot of people were not too excited about that. And frankly, I thought, well, what the heck? Let's give it a shot, before we go in for surgery or anything like that. Well, anyway, here we are 2.5 years later. And it went up to an 8, slowly trickled up more or less linearly to an 8 again.
Okay.
And that was just before August. And I had 2 PET scans in Oxuma. And
hold on, Dave. Let me just hold you a second, because we will definitely come back to you, and I want to take your history down as we speak. But I just want to acknowledge that. Since it's been such a long time, we'll kick off with Willie and with yourself, and then we'll work through everybody else. Let me, since there's nobody that for this particular group that's new other than Willie, let me just run down everybody right now and see who needs some time today, and then we can figure out how much time we can spend with Willie and with Dave. So, Jake, did you need any time today?
No.
Are you sure?
Well, if you don't have any time, I did talk to my doctor about my rising PSA.
Okay, well, let's discuss that. So we'll give Jake a little bit of time. All right,
Okay.
I'm just giving you a heads up. All right. Dennis, would you like any time today?
Be right back.
No, maybe in another 2 weeks when I get my new labs and so forth done here. I might have
Okay.
some new information, but right now I'm good.
Okay. Carl, hello. Would you like some time today?
Well, I only have about 20 minutes. This is the eve of my operation. Having tomorrow morning.
Okay,
So,
well, then in that case, we will stop by you, and right after the meeting, I'll send you. I forgot to do this. I'll send you our surgery tips. Okay, because we have some surgery tips.
Okay.
Which I don't send out much anymore because we don't have a lot of people who are pre-surgical here. But I will definitely send you some surgery tips, and there may be some guys, I'm not sure if there are on the call, who have had surgery that may have some ideas. But okay, and if you only have 20 minutes, we'll promote you as well. Rich, anything for you?
I get blood drawn tomorrow, so at the moment, I'm kind of in neutral.
Okay. John Appler, anything for you?
Hi, Rick. No, I'm like the other guys. I have blood tests back next week, so maybe then, hopefully not too much to say. Thanks for asking.
We're going to have a busy call next week, I can see.
Yeah, exactly.
Okay, Professor Bill, I know that you've got some interesting stuff to talk to us about.
Yes.
Thanks. Okay. Paul Frieder, anything for you?
Nothing for me, thanks, tonight.
Okay. And Sylvester, anything for you?
No, thank you.
Okay, so since Carl is pressed for time and is going under the knife tomorrow, then why don't we just start with you, and then we'll talk to Willie, and then we'll talk to Dave, and then I'll move through the rest of the list. So Carl,
Yes.
Tomorrow's the day, huh?
Yes, it was last minute that I actually found out that it was going to occur, because I had a phone call early this morning around 8 a.m. from my insurance company informing me that they've declined the procedure. And that put us into somewhat of a panic mode and say, okay, well, are we going to have this surgery or not? So after many hours of, I guess, behind the scenes going back and forth with Cancer Institute of New Jersey and members of their staff and the head surgeon, Dr. Kim, they ultimately resolved as of 4:30 this afternoon that, yes, I will be able to have my surgery tomorrow morning. It's going to be at 9 o'clock. I've been told it should take somewhere between 5 and 6 hours, and that I am expected to be released the next day. And I'm finishing my prep right now. I have the magnesium citrate that is supposed to have me go. And although I've been peeing, I haven't gone much the other direction. But hopefully this will do it right now. And I'm supposed to have an enema. Not to get too graphic, but I'm scheduled to have an enema around 8 o'clock tonight and be up early in the morning.
So if we see you dash off in the middle, because sometimes you don't get a lot of warning, just saying, we'll understand where you've gone. If you say gotta go, we got it. Okay. When you say gotta go, you really mean gotta go.
Right. And something kind of interesting has occurred in addition to all of this. I've come down with an apparent autoimmune disease called bullous pemphigoid. I had never heard of it before. I've been told that it's quite rare. For the past couple of months, I developed a rash, a skin rash. I've gone to several doctors. I've spoken to several Amgen and Genentech, the companies that are who produce the medications that I take, whether it's Zytiga or Xgeva. The likeliest culprit at this point could possibly be Xgeva, where they say upwards of 15 or 18% of people who take that medication do come down with some type of a skin rash. But prior to that, I've had multiple doctor's appointments with my primary care physician, who informed me, he said, well, it looks like folliculitis, which is a bacteria that gets into the follicles of the hair. And he asked me, well, were you in a hot tub recently? I said, well, coincidentally, I was a week earlier, and he put me on antibiotics. Nothing was working. I went back for a second meeting with a different doctor in the same practice. He told me to use a HIPAA cleanse for my skin, and I was doing that. It seemed to relieve it to some degree. But then I finally went to a dermatologist, and the dermatologist said that it looks like it's an allergic reaction. So he has a steroidal cream for you to put on the bumps that I have, red bumps. They're itchy. Some of them develop into blisters. And so that kind of wasn't working. I went back again to the second dermatologist within the same practice, and he said, well, do you have any dogs in your house? I said, I don't have a dog, but we babysit on occasion our daughter's dog, who unfortunately passed away recently. But he said, well, you might have fleas in your house. So multiple thoughts about what this rash could be. And the latest was that I had a skin biopsy about 10 days ago, and it came back last Thursday saying that I have this bullous pemphigoid. But the dermatologist said, well, that's not definitive. You have to have a second biopsy, and you also have to have a blood test. And he said, since you're having surgery next week, meaning tomorrow, he said, well, there's no rush for you right now. Do it after the surgery. Well, I don't like to postpone things if I don't have to. So I did have the follow-up biopsy. I'm still waiting for the results. I had the blood work, waiting for the results with that to definitively determine, and yes, I have this rare autoimmune disease. And there was coincidentally, and there's foundations for everything. And I found there is a foundation for this disease. And I saw that they are having a support group meeting this past Sunday in Midtown Manhattan, and I attended it. I met with a bunch of people, still not knowing if definitively that's what I have, but I have more information. And as you know from previous discussions, I'm very much into being proactive with my health and doing as much research as possible to make sure I'm on the right track. So that's where I'm at now. They're saying, well, it could be stress related, but it's red spots, some turning into blisters, primarily in the ankle, the feet, the hands, and it's annoying if nothing else. There are people who have a variant of this type of disease, which is much more serious from when it was described to me, where people have blisters in their mouth, and it's very painful, and they have difficulty eating. But that, thank goodness.
Let me ask you a question, which occurs to me. Are there any, since it's an autoimmune disease, I'm wondering if there are any mutations that are associated with it. Have you discovered any mutations that are associated with it that you might harbor?
Well, that is a possibility. There's a well-known doctor out of Mount Sinai who's a specialist in this particular disease. I haven't been able to follow up. I'll see whether I will need to or not after the surgery, but that's a possibility.
Professor Bill, does it ring any bells with you? Genetic mutations associated with autoimmune diseases?
No, I mean, some autoimmune diseases are triggered by mutations, but this is not a disease that I had ever heard of before. I'm reading up on it as we're speaking.
Okay.
It's new to me.
Okay.
As it is to me. And the foundation, and speaking to them over the weekend, they're very interested in spreading the word to dentists in particular, because they're like their initial line of defense. When people have dental exams, they look inside their throat, inside their mouth, and they may indeed find these blisters that people may or may not have. But the common theme of the other people who attended this support group is that all of them had similar types of experiences where they went to multiple doctors and no one could really figure it out because it's so rare and most doctors don't even know what it is. But hopefully it's going to be on the right track for me.
So what doctor was it of yours that actually figured it out?
It's the dermatologist who I went to most recently, and the one who actually said he believes it's bug bites, but he said, "Well, let's take the biopsy to make sure." And that's when it came back.
So I've got an assignment for you. Since you have now broken into this bolus pemphigoid support group, which is that if they have any interest in creating a virtual group like this, and because it's a rare disease, we'd be happy to work with them and to sponsor them.
Yeah, that would be a great idea. I would definitely follow up with them. They're out of California as the main office, but yeah, that's a great idea.
But just tell them that, we'll help them, and it might well be a very good idea because people are spread far apart, and it gives the opportunity for people in remote places to come together. Let me go back to your prostate cancer for a second. What were the reasons why the insurance company at the last moment gave you such a hard time?
Well, they're speculating as to exactly what it may have been, and because I'm in the clinical trial, and that in my case where I have metastatic prostate cancer, the standard of care is hormone therapy, which I'm having, but it's not necessarily also having surgery. So I did ask the insurance company what specifically, but they really did not have an answer for me about it. But now, ultimately, again, it's a moot point because they did come around. They spoke to Dr. Kim and now said we're good to go.
Yeah, I mean, my guess would be that because you're metastatic, that's why they turned you down, because this whole concept, which we've talked about many times on this call, of debulking is not something that is that common for in metastatic. I have sent you, I emailed to you whilst you were talking, I emailed you the surgery tips. Take a look at them, especially since there may be a couple of things that maybe you want to send Eileen out to pick up from the drugstore tonight that you might want to take in with you. These tips have been generated by people that have had surgery and what their experience has been whilst they've been in the hospital and afterwards. So you might find some useful things. One thing that a lot of guys find very, very helpful is to rent, if you don't have one, to rent a recliner, especially the type of recliner that sort of tilts forward to help you stand up. So you'll see that's in there. Another thing I want to mention to you, don't let them kick you out of the hospital too soon. If you feel you need to stay an extra night because you don't feel ready to leave, or you have some pain, you tell them that you need to stay an extra night. Okay. I mean, a lot of guys will tell you the same thing. Some are ready to go. A lot of them feel more comfortable staying 2 nights in the hospital rather than 1 night in the hospital.
Okay.
So don't be shy to do that. Let me
checking my email. It hasn't come in yet, but I'm sure it will shortly. So.
Well, yeah, I sent it a little while back. So yeah, keep looking. It's from Ardi at Ancan.
Here, I got it.
Oh, you got it. Okay. Has anybody else on the call had a radical prostatectomy?
I had a radical prostatectomy.
Sylvester. Okay. And what is there anything from your radical, which it was a long time ago, so I'm sure it was an open radical, but is there anything that you would like to mention to Carl that might be helpful to him before he goes into the hospital?
Well, I had a pretty successful event, but there was one little slight error that I had anticipated, and I don't think my doctor anticipated. That is when they took me off of the intravenous medication and put me on pill. I think the nurse had their own agenda because the doctor told me clearly to ask for pain medication. And of course, I asked 3 separate times, and it never occurred. But my doctor came later that night, I think it was around midnight, maybe a little later, just to check. And what happened, to relieve my pain at that particular time, he ran, I don't know what the name of the instrument, but he ran a tube down my nose. And that seemed to relieve quite a bit of the pain. But other than that, my operation was smooth and I had a very good recovery. The only suggestion I can make is that when the catheter, because I was sent home with a catheter, when the catheter was removed, I was not prepared because the doctor didn't tell me either. I was not prepared that I needed some pads to catch the urine because the catheter was removed at the doctor's office. I think the catheter for me was for 2 weeks, if not 3 weeks, and I went to the doctor's office to have that removed. But those were the only incidents that I remember that took place with my operation. But overall, it was successful.
Okay. Well, thank you very much, Sylvester. We do have people. Bill Franklin, for example, had a radical prostatectomy. That's one name that comes to mind. Peter Kafka had a radical prostatectomy, and
This is Paul Frieda.
Sorry?
This is Paul Frieda. I had one too.
Oh, well, you didn't speak up.
Well, I had one person at a time. I didn't want he took the floor.
Okay.
Yeah, I had one at the Memorial Sloan Kettering.
What advice do you have for Carl?
Well, I don't know. Mine went awfully smooth. I had no pain afterwards. One thing is that I had to go home with a catheter, and I felt so comfortable with the catheter, I almost took it out myself, and that would have been a mistake. So, even though if you feel really comfortable and you think you can take out the catheter by yourself, don't do it. I had mine in for a week to 10 days, and then when at the doctor's office, the nurse took it out for me, and I had a pretty very smooth operation. Never had any pain. The one problem that I had was that they wanted to get me out of the hospital like in one day, but Medicare won't. And I didn't have anybody take care of me. I was living in Thailand at the time, and so I needed to go to a nursing home when I left the hospital. And if I had gone out after one day, Medicare would not have covered that. So I had to fight with them to let me stay in the hospital for 3 days, and then I was able to go to the nursing home. So the nursing facility, and so I don't know if that pertains to you at all, but yeah, the funny thing is when I got to the nursing facility, after a couple of days, I ended up speaking to my surgeon, and he told me get the hell out of there. He said there's so many bacteria places like that. You go home as soon as you possibly can, and I checked out that night.
Well,
You have any questions about it? You know, in your mind about uncertainties or anything?
Carl, you may be muted. We're not hearing you.
Right, you're right. I was muted. Okay, so I'm not Medicare yet. I'm going to be 64 in a couple of weeks, and so that's not an issue. Yes, I will have the catheter in. They said it's a minimum of 8 days. 8 days comes into Thanksgiving. They were going to be closed, so it probably won't be removed by the nurse until the following Monday or Tuesday, and so. You know, the doctor is very confident, as I think they need to be, and they should be, that it should go pretty smoothly, although he did say it's going to be somewhat complicated, that it may involve the neck of the bladder. They are going to remove some lymph nodes just to make sure to test for any microscopic additional, you know, inclusions or whatever. And they also were proactive. They had me meet with a doctor who deals with incontinence issues, whether it be the need for a sling or an artificial sphincter, and penis implants, penile implants. They talked about
why do you think you might need that?
Well,
sounds like somebody scared you or something like that. No, I mean, and normally, unless you have some unusual you know, anatomical problem, the catheter comes out, you will be incontinent for, you know, for a couple of weeks, maybe even a month or two, and then it slowly gets better, and then you should be pretty much okay. Although for me, it came back, and now I wear pads all the time. But my surgery was in 2014. That's almost 5 years now. But I have to wear a pad every day because it's mildly incontinent. And so, but to need a sling or surgery is that's I don't think that's very usual. I think we had a guy on here, Jim Harrington, went through that sort of thing, and he had some strong opinions about what you can do and whatnot. But yeah, I don't know why you think you're going to need something like that.
Well, no, they don't think so, nor do I think so. But they're being proactive with this doctor, who I read, by the way, on their website, that he's relatively new to the group. So I think they're trying to get him in front of patients, if nothing else.
All right. So, is there anyone else that would like to say anything to Carl before we move on? Or before he quickly moves on? I'm getting very nervous here.
I have something to say to Carl. And maybe you remember, Rick, that Michael Seidman, when he was going through his radiation, developed horrible skin rashes all over his body. He went to a number of dermatologists. They talked to him about, these rare autoimmune skin disorder, just like you're talking about, Carl. And in the end, he was just nervous. He was very anxious, and ultimately it just completely resolved by itself. So,
possibility.
try Xanax or Ativan or something just to relax.
Right.
Maybe that would help.
They did definitely say that being nervous is what brings it out as well. But it's been several months, and I'm pretty calm in lieu of the fact that I'm having surgery tomorrow, so I'm pretty confident I'm calm about it. But still have those itchy bumps.
I didn't realize it was going on for months. I thought this was just like in the last 2 weeks.
No, it's started in mid-September.
Okay.
And at around the time of my first Caregivers shot.
Jake, go ahead.
I was just going to ask Carl if they had ruled out allergies.
Well, one of the dermatologists who I met with did say he believed there was an allergic reaction. He gave me a steroidal cream, and he said within 3 to 4 weeks, it'll all be resolved. Well, no, it hasn't been.
Okay.
Have you tried like an oral antihistamine?
No.
Like Benadryl or Claritin, just they're pretty much harmless. It might be worth a try. Certainly not before your surgery, but afterwards.
Yeah, all right. Okay, I'll consider that.
Anyway, good luck. Good luck tomorrow. I'm sure
Yeah,
you'll
good
do
luck.
fine.
Yeah. Thank you. So I do have to sign off. So I appreciate all of your support, and I look forward to seeing you guys on the other side.
Okay, Carl, be in touch with me and let me know how you do, will you? And check those surgery tips right away.
Yeah, I tried printing it. For some reason, it was only the first page, and then it says something incorrect paper size detected. So I got to figure that part out. So
Okay.
Carl, before you go, this is Bill Burhans.
yes.
I've been doing a little research while we were all talking and learned that there is a genetic component to this autoimmune disease. And there are some clinical trials ongoing that are trying to better characterize it. So if the diagnosis turns out to be correct and it continues to be an issue, you might want to look into that.
Yes, there's also a drug that everyone was raving about that recently got FDA approval over the past few months, Rituxan, which I think is also used for some other cancers. But and it's not deemed to be a chemotherapy; it's a biologic, as they keep calling it. But it's also done via an IV, and it has potential very dangerous side effects. But so far, the people, at least at that support group, who are raving about it, that it's something relatively new and it's a godsend. So, yeah, there's things to look forward to.
Okay, good luck with it.
Okay, signing off. Thank you.
Okay, good luck. Bye. Okay. Let's move on and talk to Willie. Willie, just give the guys just a short idea of your background, of your prostate cancer background. We don't want to get into your military activities. It's okay. But give the guys just a brief idea of your prostate cancer background.
Yeah, absolutely. I was diagnosed with prostate cancer in 2011. It was, I was in one of my trips. I came back. I was not feeling well, and I just threw a physical, and they checked. The doctor checked my PSA, and then my PSA was elevated, to like 6.4. Did the biopsy, and it came out that I was, that I have prostate cancer. So they told me that they were able to point the cancer, early on. So I decided to go with the radiation seeds, and that was the treatment that I chose. When I was initially being counseled about the radiation seeds, that my doctor said I needed to take about 5 weeks of external renal radiation treatment, as part of augmentation of the treatment. And I told him that I did not want to do that. I just want to focus just on the seeds, because I was trying to minimize collateral damage. And well, I did that, and after 2 years, my PSA dropped from 6.4 to 0.27, which is that's what I have right now. So, and I've been just watching over myself, make sure that I did that every 3 months treatment, every 6 months, and now I've been doing like every year a visit to my doctor. And last year she broke up with me. She told me that there's no need for me to come back. So
okay, those are the sorts of stories.
I'm sorry.
Yeah, no, those are the sorts of stories we like to hear. Unfortunately, on this advanced call, we don't hear them too often. So, but if you join Peter's call, the intermediate call, which was yesterday, I think, I have to make sure Peter's got your name on his distribution. I'll do that. Then you'll be speaking and hearing a lot of people that are a lot closer to the situation that you're in. So so that's it. So again, I really I really want to thank you for volunteering here. Is there anybody that would like to say or anything to Willie or to chat with him, other than about the good weather in Florida?
And the tan.
And
This is Dave.
tan.
Dave Sanders here. I wanted to ask William if he's had over the 2 years any side effects that have developed, because sometimes it occurs over long term with the radiation, even with the brachytherapy. So have you had any urinary urgencies, things like that, or colon, or frankly even ED? I'd like to hear if you've noticed any changes over the couple of years you've been on seeds.
I think I have been fortunate. I think that I do my frequency, my urinating frequency is now, I guess, bigger, larger, because, I tend to go to the bathroom a lot. At times I feel that if I don't go, I kind of I feel like, that I will have an accident, but luckily, I haven't had, much of an issue. In the beginning of the process, within the first year, I guess just like any other procedure, it was my biggest issue was issues going, issues urinating. Never had any constipation issue, and I feel very fortunate that I have not had any issues with so I guess, I'm feeling, blessed, I guess, that I have not had a lot of issues with it. So, but I'm pretty critical about my body and what I eat, and working out and trying to stay in shape, and trying to always looking out after my health, just to kind of help with the healing process and make sure that this doesn't come back. So does that answer your question?
Yes, thank you. Yeah.
Maybe you and Bill will meet up with Len when you're down there, because Len's going to be an hour and a half or so south of you. Isn't that about right, Len?
Yeah, normally I'm in Sarasota, just an hour south, but this winter I'll be in Venice, a little bit further south.
Okay. I'd love to buy you lunch or cup of coffee if we can meet up once you gain your tan. Though you gotta be tan.
He's Italian. He tans very easy, Willie. He's Italian.
So I think that we're gonna get together, sooner than later. Then I look forward to it.
Yeah, Willie, what was your Gleason score?
I'm trying to remember. I thought initially there was, I think it was 3-4 based on what we talked, right, Rick?
Mm-hmm.
Yeah.
Yeah, I suspect it might have been, it was 3-4, or it might even have been 4-3 if they wanted to do 5 weeks of radiation ahead of time, but we're not sure.
Yeah, I gotta look it up. I have my records, and I'll make sure that I can answer that question next time we talk.
Okay.
But and once again, when I first got it, when I first diagnosed, I'm pretty sure that you guys went through the same, kind of ruins your day when somebody tells you that that you got cancer. So as any good paratrooper, immediately after leaving the doctors, I went straight to a bar, and so I can think operationally, and I treated this like any other mission I've ever participated on, and I just I had I did as much research as I could, but I made sure I had a physical fitness plan, and I had a mental health plan. So I started seeing somebody, make sure that my head was straight in the right place, and then and I was working out as much as I was when I was active duty, and didn't have this gray hair covering me. So, and I think that all of that kind of helped me. I was mentally and my psyche was really good, and physically I was, cardio was really high, and strength was really high. So I think that really helped me. during the recovery process. You know, I took it as I am going into battle. So that's how I took it, and that's how I approached it, and that's how I still approach it. So
God bless you.
thank you.
God bless you. It actually raises a really interesting point, guys. I've been working this week with a fella. I've known him for a while. He's the best friend of a close friend of mine. And about 3 weeks ago, he had some bladder issues and some frequency issues and some difficulty peeing. I talked to him about 6 weeks ago or 8 weeks ago. Dave had him call me and we talked, and he was catheterized for quite a while, and then they removed the catheter. And then about 2 weeks ago, he went back in and they did some more scans. He got diagnosed with a large tumor on his pancreas. And they biopsied it, and it turned out that it was a neuroendocrine tumor, which is a little different from most pancreatic cancer. It's actually the type of tumor that Steve Jobs had. So it doesn't have as bad a prognosis, because normally, as most of you know, pancreatic cancer, we're talking months. With neuroendocrine pancreatic cancers, we're talking years. But this guy has just disposed of it as if nothing happened, and finished up going to see a surgeon rather than a GI medical oncologist. He needed to see a gastrointestinal neuroendocrine endocrinologist, because it's pretty specialized, oncologist, it's pretty specialized. But he didn't. He went to see this fellow at Cedars. He lives in Southern California, in Cedars-Sinai. And this surgeon said to him, "Oh, I'm just going to take it out and you'll be fine." Well, you know, we know that's not the case. But that's where we were when I talked to him this morning. And it was just, rather than getting all bent out of shape because he had this cancer, he just had sort of made very little of it.
Rick, you just froze. We can't hear you, and your image is frozen. So I think, well, until Rick resolves that, maybe we can move on. Jake, did he want to move on to Dave next, or to?
Okay. Rick, we missed everything you said. We froze.
Oh, I froze?
Yeah, you were talking about your friend with the pancreatic this morning. Something happened this morning, and then after that, we lost it.
Okay, well, what happened this morning was he told me that it was all going to be fine because he'd seen a surgeon, a transplant surgeon, and the surgeon was going to remove this tumor, and the likelihood was that would be the end of it. At the same time, he was sending him for a gallium scan. And I said, no, it's, you know, the likelihood is it could have metastasized with a tumor the size you have. And so anyway, we've straightened him out. We're sending him to the right person. But rather than just going over the top and being super anxious, he's been very calm. So more power to him.
Yeah.
Okay, Dave Sanders, why don't you tell us a little bit about why you're back with us?
Yeah. Let's see, do you guys have my video now, or?
We do.
Okay, yeah. It was going through a hub, so maybe that was it. I plugged it into the computer direct, and that seemed to have solved it. So anyway, good. So yeah, as I was saying, where I'm at now is after the first FLA, focal laser ablation, a couple of years ago, everything seemed good. You know, went from, I had a Gleason. It actually ended up a Gleason 3+5. They said, but just a little bit of 5, you know. So I don't know. I will say that there's quite a variation in. I had it I had it. I sent it out to get a second opinion, and to 2 different places. Hopkins was one, University of Washington, Seattle, and OHSU here in Portland, Oregon. And OHSU did the original, and they came out with a 3+4, and a 3+4, and they came out instead with a 3+5 at the other place. Anyway, so did the focal laser ablation, went from PSA of 8 down to 1. That felt good. Then it creeped up, and so then just this summer, while it's sitting at about a PSA of 8, I've been having MRIs every 6 months. They said, well, nothing, don't see nothing here. And oh, by the way, I became sensitive to gadolinium, so I just cannot take those scans anymore. So I get those hot burns up and down my legs and everything. So gadolinium is definitely an issue for some of us. So anyway, I went and had an Oxuma. It became available here, so I had an Oxuma, and it hardly showed anything. Just a few little freckles in the middle of the nothing, no metastases, just a few little dots on the prostate. But the PSA continued to rise, so I went to Arizona, Phoenix Molecular down in Phoenix, and did the C11 acetate, not choline, but C11 acetate. Lit up like a Christmas tree. Nice solid indication right in the middle of the prostate. They called it like medial left, and whereas the original cancer was in the right peripheral. And so with that, had another focal laser ablation. And I actually talked him into doing the focal ablation without even a biopsy. Just go in there and just burn it out. They took the biopsy right there at the table, but they did the focal laser ablation at the same time. Biopsy came back a 4+4. Did the focal laser ablation. Here I am 3 months later. Just had the first, PSA, not good. 6.5. So went down a little. So it could be, of course, one of the spins is that it's what the doctor says is what he sees a lot of is kind of an autoimmune reaction to focal laser ablation, leaves the cancer cells, dead cancer cells behind. Then a reaction forms, raises PSA, similar to like a prostatitis. In fact, I was in, as it was before the second ablation, I was in consultation with him, and he said, well, wait till when it gets to 7, then we got to do something about this, because he was so sure it was a reaction to the first ablation. So here I am. I've gone through 2 focal laser ablations, and I'm sitting at 6+5. No metastases are at least showing up, within the resolution of those PET scans. And everything's contained within the prostate. Of course, I'm going to have another. I'm having a PSA every month. I went to a doctor who says, just give me a slip for every month. I'm going to be watching this. And so the reason I was really interested in Willie's discussion is because brachytherapy is something I would consider now. If I want to stay away from radiation. I'm under no illusions. I'm kind of in a whack-a-mole situation here. My company has been paying for this focal laser ablation, so I haven't had to pay anything for any of this stuff. Oh, I had to pay the $3,000 for the acetate scan. That was under trial. It's still under a trial basis, not FDA. But as you know, Oxuma is FDA.
Let me just You're talking
Yeah.
about Axumin, I think.
Yeah, Axumin. I should pronounce that correctly.
Okay.
Axumin. Yeah. Yeah.
The scan you did with Almeida was a C11 acetate, or was it a gallium 68?
No, not a PSMA. You know, it was a. He only does C11 acetate. They've got an accelerator right there on site.
Right. No, he's doing. He's got a gallium 68 trial going on right now with PSMA R2 or R3. Yes.
Oh, that's good to know.
Yeah. And he's testing out this. He's using a different PSMA agent. Is what they're trialing, and he's trialing it both with the gallium 68 and with the lutetium for different purposes.
No, I don't want to do that. I wonder what he wants to do price wise.
Well, it wasn't expensive. I mean, he was offering that at a very, very low cost, but I'm a little puzzled that the Axumin scan showed nothing, but the C11 showed within the prostate, but it didn't show anything outside the prostate.
Yes, that's right.
Okay.
In fact,
so Len, let me ask Len a question. In fact, I think I'm going to turn the moderation over to you, Len, for a few minutes. Would the Axumin not show within the prostate and only show in the lymph nodes?
No,
Axumin
should show lesions in the prostate as well. And it's generally recognized as being more sensitive, slightly more sensitive than the C11 acetate and C11 choline. So I'm as surprised as you are, Rick, that the Axumin didn't pick up lesions that the C11 acetate did. That's very unusual. And Dave, at first I thought maybe I misheard you. I thought you said the C11 acetate showed, I think you said lit up like a Christmas tree or something like that. And I was thinking that sounded like metastases, but you're saying it just picked up a lot of lesions within the prostate. Is that right?
What I meant to say was just to contrast it with the Axumin. And you can see here's one, if I can, you can see that dot right in my prostate there?
Yeah.
And here, and this you won't be able to see too much. This was the Axumin, I think the colon is shown there at the top, the black circle, and you see that little white dot just below that, and that was about the extent of the Axumin. It's still about in the same area as the C11, but it just was, and they basically just said they said no evidence. Mild asymmetric radioactive activity. Left prostate gland could be due to inflammation given diffuse appearance, but residual prostate cancer cannot be excluded. That was the Axumin. But the C11 acetate, Almeida said, well, it looks like cancer, and his analysis was. Increased metabolic activity left peripheral zone of prostate gland concerning for new malignancy. So I took it as a new cancer over there because we didn't ablate that site at all. We didn't get in even to the center of the prostate. We were totally on the right side on the first ablation. And it brought it down, as they say, to a PSA of 1. I mean, it was awfully good news, but obviously it crept up. So, so where I'm at, I know I'm thinking I should have listened to Rick 2.5 years ago, but at this point, but because I know at the time, you thought I should attack it aggressively, and I was scared to death of, you know, RP and radiation therapy, and so I tried this new thing, you know, and at first I thought, well, this is great, it worked, and it bought me 2.5 years, and so now I don't know. Now I'm very worried again. I sent an email off to the doctor. Hey, I'm at 6.5. What happened? And he hasn't gotten back to me. So what my next step, the way I feel my next, and I'm throwing it out there. I mean, for you guys, you know, because I may be still irrational about it. I'm thinking we're only 3 months post FLA on this thing. That I'll take the next PSA in the next month, and maybe wait another month or two. And if the trend is up, then I go in for a scan again, and maybe I talk to Almeida again and have a PSMA. Make damn sure that they still can't pick it up, any metastases, and maybe he can get a better picture inside the prostate with a PSMA. Because I'm wondering if PSMA maybe isn't so, you know, this acetate could be picking up metabolic from inflammation also, because I know it was glowing around the other side of the prostate a little bit too, but usually you're looking for bright dots rather than an overall glow. And usually an overall glow means that there's kind of more of a diffuse kind of an inflammatory response. But, you know,
Len, what are your thoughts?
Did you say that Almeida or someone biopsied the lesion they identified with the C11 acetate, Dave?
No, I didn't. I didn't go in for a biopsy actually, and but the FLA doctor agreed to. He said we can do it 2 ways. Then we can do it right. We can do it the day before the scheduled FLA. We'll take a frozen biopsy and have that examined. It's not quite as good as taking the time for a full biopsy, you know, and having the pathologist take a couple of days with it, you know. But he says, and then he comes back later in the day or the next morning and says, we're positive, then we go in. I said, well, you know, I really don't, I hate biopsies because I was damaged on the first biopsy is all. That goes back 2.5 years ago. Really, it hurt me bad, even though it was a guided one. I don't know, he hit nerves, or I don't know what it was. But so he said, okay, so what I'll do then, we'll just go in there and burn it because we can do this. It's not on insurance, it's private basically. So we'll go in, but I'm taking a biopsy when we go in, you know. I said, fair enough. So he went in based on the scans. Biopsy came out. 3 days later, it was a 4+4. So I can only assume he burned it. But
so let me stop you because I want to get some discussion going on this and some alternatives for you to consider.
Yeah.
I mean, Len, in this set of circumstances, if it was you, what would you be doing?
If it was me, I would go to an NCCN hospital. Where do you live, Dave?
Yeah, Vancouver, Washington, Portland, Oregon area.
Well, they have a pretty good cancer center in Seattle, don't they, Rick?
Right, exactly. Oh, that's where I would go. Yeah.
Yeah, they have a very good center at OHSU as well, led by Thomas Beer.
Yeah.
Yeah, one of the best.
They would probably want to do an MT MRI, and then do a targeted biopsy. And with a 4+4, I think I would not play around with FLA. I'd be done with that. you're 0 for 2 so far with FLA. So, you know, don't keep doing the same thing when it's not working.
No, I know what you mean. You know, the trouble is the MRIs aren't showing it. So I got 2 issues with MRIs I've had all through this last 2.5 years. It was not picking up anything. All it was, in fact, all they kept picking up was, well, you know, that right side, there could, and you know, maybe that's the problem. Maybe it's the right side again.
Dave, let me say this. They don't need to pick anything up.
Yeah.
They don't need to pick anything up. They know you've got 4+4 cancer.
Yeah.
And they know that your PSA is rising. So it isn't like we've got any doubt that your cancer has recurred.
Right.
And if it was me, I know what I'd be doing. It isn't what you'd want to do, but I know what I'd be doing. I'd be doing radiation therapy. I'd get my pelvic girdle radiated so that it covered all of the pelvic lymph nodes. And I might get my gland radiated again if that was suitable. I mean, it would be up to the radiologist, but I'd get the gland radiated. And I'd probably go on a couple of years of hormone therapy and hope that really nailed it, because there's a chance that it could. And as Len says, with 4+4, you don't want to mess around. You don't want to let this get to a point where if there is micrometastasis, it becomes full metastasis, and then you're dealing with managing this for the rest of your life.
I know.
So
I know.
you can sit there and say, you know, I really don't want to do the radiation, but that's fine. But realize that when you're doing that, what you're going to be doing is opening yourself up to being on hormone therapy for the rest of your life, and chemotherapy, and maybe some more radical treatments. So your choice is either to try and nail it now whilst you can, and I agree with Len, at a center of excellence, either with one of the good, I've got a couple of names I can give you at Seattle or at OHSU, who's very, very good, and go in there and meet with I think I don't know, either the radiation oncologist or a genitourinary medical oncologist for guidance, and see what sort of program they put you on. But if it were me, it's a no-brainer as to what I would do.
Yeah. You know, the thing, I know, Rick, I remember you saying on one of your, I think on one of your posts that, anxiety, you never were troubled by it. I was also very sensitive to chemicals and everything. I don't know that emotionally I could survive. I know everybody reacts differently to ADT, but I think I would not handle that well.
Well, but what's your alternative, Dave?
Die.
Okay, but if your alternative is to die, then either you, and I'm not being flippant about this. Either you remain in Oregon, where at least you've got an end of life act. But what you don't want to do is you don't want to die from prostate cancer.
No, I don't know what, of course, now we're getting deep into it, but I just, I don't think I could go on. And if it got to that, if I made the mistake, if I pursued this and it metastasized, and who knows, I might even try the shots. And but if it just made me feel awful, I would take care of it. I think I could take care of it. I just couldn't. I don't think I could. I don't have family or anything, and I want to live. Don't get me wrong, but I just don't know that I could I couldn't deal with this as a chronic issue for the rest of my life. I don't. I'm extremely athletic and everything, and I just don't know that I could take to see my body get torn down.
But you know, why do you think I did 2.5 years of hormone therapy? I exercised every day.
Yeah, and you didn't feel you felt some guys. I just, like I said, that's why I'd probably try it. But
how did I feel? I didn't feel good. And I think most everybody on this call who's been on hormone therapy will tell you they don't feel 100%.
Yeah.
But Professor Bill, you must be having a bunch of thoughts here. Do you want to have a little chat with Dave? Bill, are you there? Well, maybe, did we lose Bill?
No, he's there. His mic is live. He may have fallen asleep.
Yeah, I was stepped away.
Or stepped away, yeah.
Yeah, well, are you there, William? Okay. No, because I'd like...
I am here.
Oh.
Bill, are you there?
Rick, are you looking for me?
I'm looking for you, yes.
Yeah.
I am looking for you.
I had to go downstairs to get a power cord from my computer.
Okay.
But
Are you back?
We thought you'd fallen asleep on us.
No. Sorry.
Did you hear Dave? Did you hear Dave? I wanted to get your opinion for Dave on, how would you proceed with this?
I only missed the last couple of minutes.
Well, the last couple of minutes were kind of critical, and what Dave said is he doesn't know that he could handle hormone therapy or chemotherapy, and clearly doesn't want to undergo the pain from final stage prostate cancer. So he lives in a state where he could take care of this in other ways in Oregon. But I'm wondering what you would like to say to him.
So Dave, are you still there?
Yes, I'm on camera.
I think the first thing I would say is to reiterate what I think Len said initially. You with a 4+4, you really need to go to a comprehensive cancer center, and the one in Oregon is terrific. The Fred Hutchinson in Seattle is even better, but Oregon would be fine. So I think that's the most important thing, and listen to what they have to say. It's scary to hear anybody with a 4+4 indicate that they're that they're not going to go through ADT. I think you have to rethink that. I
do have an appointment anyway. In fact, I've got one urologist at OHSU that I see, and they wanted me. They're pretty traditionalists there, and they wanted me at the time 2.5 years ago, of course, to they have you talk to a surgeon. I think maybe it was Beer. Does he do the chemo? He does. Does he do ADT? That fellow named Beer that you mentioned.
Yes.
Yeah. I talked to him, and then I talked to Arthur. I can't remember his last. The radiologist. So I talked to all of them, and so they all talk to me about their specialties, and they all each have kind of a bias towards their specialty a little bit, but the bottom line is they wanted to do all of those things. But that was why at the time, though, I thought, well, let's give this a shot of FLA, and it was a gamble, granted, because it was serious back then. Pretty good sized tumor on the peripheral.
So I want to pull you back. I want to pull you back to what we're doing now. I mean, I don't want to go back. I don't want to go back over what we've done because we've got 2 or 3 guys still to talk to, and I want to make sure we have time. But you know, I understand that there are some issues here about how you feel you can tolerate the treatment. But the one thing I do want to impress upon you is that if you have any chance to avoid metastatic prostate cancer, and in particular passing from metastatic prostate cancer, grab them. I mean, that's not medical advice. That's just common sense and the observation that I make from having seen too many people suffer with metastatic end-stage prostate cancer. So I really want to impress that on you. If it were me, as I say, I'd be jumping in with 2 feet right now, doing the radiation and doing the hormone therapy. I think we can support you through the hormone therapy. We've done it with other guys who have had difficulties. But I think you've got to be in a frame of mind that you're willing to stick with the program. And you've got to figure that program is, because you still have a chance of going in, doing the hormone therapy, and being done afterwards, which most of these guys on this call are not. And that means you're going to have a couple of years of uncomfortable quality of life, but the rest of your life hopefully is going to be fine, like I experience. And that's the trade-off that you've got to look at. That there's a possibility there's an end stage. If we were talking about disease that had to be managed for the rest of your life, that's another story. But we're not talking about that with you just yet.
Right. Okay.
So, Dave, let me just finish by saying that I was not diagnosed with metastatic prostate cancer, but I became metastatic even before a year was out after my diagnosis, probably because my cancer is being driven by a rare mutation that makes for really aggressive disease. If the Axeman scan result that you obtained is correct, that there are no metastatic lesions now, that means that you have a chance of escaping metastatic disease if you attack this aggressively. And believe me, after being metastatic for 4 years, I can tell you, you do not want to progress to that stage. So you really need to think this through carefully.
Okay. Well, that's you scared me, and I need to be scared, I guess.
I'm sorry, but that was the intent.
Right. Okay, guys. Well, I thank you all.
Dave, look, keep coming back to us. Keep talking some more. Is there anybody else that would like to say anything to Dave before we move on?
Yeah, I would just reiterate what Bill and Rick have said. You have a chance for a cure, Dave. You just have to tough it out for maybe 2 years if you get radiation and hormone therapy. And after that, you could be free of all of this. Why would you throw that away? You look like a fairly young guy. You have maybe several decades ahead of you. So you have to make some sacrifices for 2 years. Hormone therapy is not always that bad for everyone. I didn't have that difficult a time with it personally. Other guys do. So you don't know until you're actually on it, but don't throw it away. You got a good chance here.
Okay, well.
How old are you, Dave?
I'll think hard on it. Yeah.
How old are you?
Oh, I'm how old am I? I'm 60. I'm 68.
Okay.
67. Sorry.
It's okay. It's all right. I'm 67
And I'm
until
not even on
Friday.
hormone therapy.
There you go. I mean, I empathize. I'm 67 until Friday, and on Friday I'm 68. So I understand. Okay.
Thank you. Yeah.
All right. Yeah, and keep coming back to us. Don't take 2.5 years off again, and talk these decisions over with us.
I will.
Okay.
Okay. Thank you.
Okay. All right, Professor Bill. Well, first of all, I just want to welcome Shref, if you're still with us, because I saw you joined us. How are you, Shref?
Good, Rick.
Good, good. Would you like to talk to us about anything tonight?
Sure, if you have the time.
Okay, we'll make time. And Les, I'm sorry that I skipped over you before. Hopefully you can check in with us and tell us how you finished up at Mayo.
Yeah, I can briefly do that.
Okay, great. So let's go to Professor Bill, and then we'll run through everybody else relatively quickly. But I know that that Bill's got some updates for us, some of which I'm aware of, maybe not all. And I know it'll interest everybody on the call. So Bill, the floor is yours.
Okay, Rick, I need to deal with something for a few minutes.
Okay.
Why don't you move on to one of these other guys, and then I'll be back in 2 minutes. Okay.
That's fine. Okay. Jake, talk to us a little bit.
All right. No big news with me, really. Just my PSA, as we talked, a couple of weeks ago, had gone from 0.7 to 1.1. A month later, it went to 2.0. And then the month later after that, it went to 2.2. So it hopefully is leveled off. I did talk, my testosterone is up to 31. It's never been below 25 anyway, but it's up to 33 now. I'm sorry. But still, still not too bad, especially if you look at the old standards of mine less than 50. I asked the doctor at your urging, what should we do? And she said, well, we're not going to do anything yet. She still uses that number of 10 or pain from me, that it's uncomfortable. And she pointed out to me, she said, I mentioned abiraterone and the 10% that Len had mentioned before, the 10% response rate. And she said, but she pointed out to me that I've been a good responder. That's the term she used, to previous medications. I responded well to Lupron, I responded well to bicalutamide, and I responded well to Xtandi. I got longer times out of it than most people have. So that's probably what we'll try next is abiraterone and see if I'm one of those 10%. So anyway, that's basically it. Nothing too exciting.
I would say it's exciting. I think, first of all, good on you for pushing her. I'd like to ask the guys on the call what they think about a threshold of waiting until your PSA gets to 10.
I would say if the plan is to eventually switch you from Xtandi to abiraterone, why wait till it hits 10? Why not make the switch now? It appears that Xtandi is not doing as good a job as it was for you, Jake. Why would you want to wait till it ramps up to 10 when you already know what your next step is? Did she explain that to you?
Well, she told me a long time ago, and I agreed with her, that she likes to stretch out, and she uses this little, thing where she stretches. I like to stretch each treatment out as long as possible. She says you do not want to do chemo if you can avoid it. I have a lot of comorbidities anyway, so I probably wouldn't be a good candidate for chemo. And she said, she pointed out that My PSA is still low. It's going up, but it's not out of control. I mean, you talk to some other people on this call, and they're in 100 to 200,000. So she points out my PSA is still low, and it's still under control. It's still the Lupron and the enzalutamide are still working. If I stop the enzalutamide and go to the abiraterone, after that I really don't have a whole lot of options. So that's why she uses the threshold of 10 or new pain or whatever. And I'm on board with that. I know this is going to kill me sooner or later. It's metastasized, it's spread. I know it's going to kill me sooner or later, so I'm just like to spread it out as long as I can. Dave has a chance to cure. Other people on this call have a chance to cure. I probably don't, and I know that, and I've accepted that, and I'm okay with that. So, abiraterone.
I'm sorry. Go ahead.
I was just forgive me. Go ahead. Whoever is that, Bill? Bill
Bill,
Burhans.
yeah.
Go ahead, Bill.
Yeah, I was just going to say, I've heard that argument before that, oncologists want to stretch a particular treatment out as much as they can to get the maximum benefit from it. And I think that's a valid approach. So I think it's a good idea to continue doing that.
Thank you.
Anybody else want to comment on the threshold of 10 and waiting until it gets to that point?
Yeah, I'm just wondering what the rationale is for the number 10. I mean, generally we talk about doubling times and that type of thing, and it sounds like you've doubled already before you go to the next treatment level. Did she give you any explanation about the why 10?
Not really, Dennis. She just, that's something that she's been doing this for 30 years, and that's the number that sticks in her head.
You got to throw out a number somewhere.
I probably will get nervous before it gets to 10. I probably will say we need to do something else before it gets to that point. But for right now, as she said, it's still low, and it did double, from June to September. It more than doubled a little bit, but then from September to October, it only went up. It's now a 7-month doubling time. So it may. I'm hoping that it has slowed down again. Maybe I've reached my new plateau for a time being. I seem to reach a plateau and I stay there for several months at a time before it goes up again. Well, I'm also trying something my wife, it's a crazy concoction that my wife made up for me. I call it a witch's brew. It's got, I think Len and Rich saw something about it on Facebook. It's turmeric and ginger and onion and garlic and distilled water and brown sugar as the medium for distributing it through your body. That's based on something my sister-in-law said. A friend of hers that actually got cured, quote unquote, not a prostate cancer, but another cancer. So I'm trying it. It can't hurt. It won't, it probably won't help, but it can't hurt. So we'll see.
Well,
it's
those
disgusting.
All of those items have good integrative properties.
Right.
Except maybe the brown sugar. Except maybe the brown sugar, right? I was just going to say, although my friend here, who's an integrative medic, has sent me something about honey being a good cure, which I still have to read. But it certainly can't hurt. I mean, anything that you do could possibly slow it down. If you can tolerate it, it ain't going to hurt you.
Right.
But I think, by and large, as everybody has said, first of all, you've got to be comfortable with that threshold number. I think a lot of the guys on this call would probably want to move before the 10. I think Dennis's point about the doubling is a good one. And I think if the doubling gets much less than 7 months, it might be time to start moving. I mean, it seems like, I'm just looking, I mean, you know, you're doubling. I don't think your doubling is 7 months, by the way. I mean, you were at 1.1 in September, and you're at 2.2 in November.
Right.
So to me that
So
sounds
2
like.
months.
Sorry?
2 months then.
Yeah. Yeah, that, I mean, I would say, I don't know when in November. I don't know if we can stretch it out to 3 months, but I would say you're in the 2 to 3 month level, not 7 months. And I think that anybody on this call who was at a 2 month doubling would be responding pretty quickly. I mean, you know, by this reckoning.
Again, there aren't that many options available. I mean, abiraterone is an obvious choice.
We can talk about that. I mean, let's not worry about the options that are available. I mean, we know that abiraterone's going to be your next one. Then we'll come up with the one after that. As long as we got one. I mean, you know, we've got apalutamide that we can use after the abiraterone. So let's just focus on what she wants to do and keep it simple with her, because we know that the more complicated therapies for you may not be immediately available without you having to travel, which we know you don't want to do.
Right.
So, you know, we want to try and stick with what's simple and readily available to this doc. And if we're going to introduce something new to this doc, we're going to have to think about how we're going to educate her to it.
Okay.
Because she's stuck in her ways. But so, you know, I would say, rather than talking about apalutamide right now, given your situation and your own issues, your own anxieties, let's, you know, talk about abiraterone. But I got to tell you something, 2 month doubling, I don't think there's anybody on this call who would not move to change once they got to a 2 month doubling.
Well, if it is a 2 month doubling, then next time I get my PSA, it'll be 4.4. If it is a 2 month doubling.
Yep.
So and I said before, you know, I probably will panic before she does. So if it goes up to 4.4, I'll probably start getting nervous, and I might start saying, we need to do something else.
Okay.
But I'm willing to wait.
Okay. All right.
It's Larry Fish. Can I weigh in?
Larry. Yes, please.
No, I'm not allowed, Jake. Well, I got you. You're on. You know, my feeling. I'm like, I guess I'm really like a step behind you, but that's not the. I know that very often that switching from enzalutamide to abiraterone may not be that effective for that long, and I think realistically you should think or start to look for a doctor or talk to your doctor about well while Rick is saying, you know, just take the next step, and I'm thinking past that. I'm thinking it might be time to start looking at the kind of trials that are out there that are starting to show promise, and maybe hooking up with people to be prepared, not to get stuck in that bind where you're starting to look for trials while you're freaking out, and when things start to look weird, and when you start to look at the combination of like a new one of the immunotherapies or radio therapies together with a new one of the newer agents, just like lutetium or another one of those possibilities. So I think it might be good for you. I don't know if that's not for your personality or not for you, but to start to look at those trials and start to see where you think you might go a year or 2 years from now, and not to decide that you're just going to take the negative route and wait for each time that something doesn't work, and then you start to think, then you make a decision. You might feel better if you start thinking about where you're going to go as a next step. Do you know what I'm saying, Jake? Or I don't know if you agree with me at all.
Larry, can I just say one thing and then I'll let Jake respond?
It's not Jake.
Sorry?
It's not for Jake, right?
Well, it isn't for Jake, and so I'm suggesting and navigating Jake because I know Jake and I love Jake, and we all do, and we know what his issues are, and the thought of him having to move out the house and find a trial and go somewhere is going to create more anxiety for him than just thinking about what the next step is. If it were you, that's what I'd be saying. But in Jake's case, I'm saying just go one step at a time and think about what you can get from your local oncologist. Because
I demur or whatever it is.
Okay,
I'm with you. I have someone I work with who's exactly the same, but she has breast cancer. And she's got this oncologist who says, well, okay, let's wait. And when you're, this chemo doesn't look like it's working, but when it stops, then we'll think. And I'm saying, you have to go see somebody. And she's not. And I'm watching things going worse. So I just had to say I had to say it, even though I know it's not.
Yeah, and I think we all appreciate it. I'm taking into account that I know how difficult it is for Jake to move outside the house. And
Larry,
really
I do appreciate what you said, and you're right. For 99.9% of the people in this world, that would be the right thing to do. I've been driving Rick crazy for the last 5 years. He finally has accepted, the way I am, and he's willing to work with me on that, and I appreciate it. But I appreciate what you said too, and what you
Jake,
say.
I really appreciate your being in the group and taking the role that you take and helping everybody. And I just felt I'd be remiss if I didn't say what I had to say before giving in to you and Rick and agreeing that.
Listen,
okay,
Larry,
I had to say it.
Larry, I'm saving the full court press until we really need it. And, hopefully by the time Jake needs lutetium and he's still as healthy as he is now, if it means that I've got to go over to Laurel, Maryland and have him sit next to me and drive him, then I'll do it, But I'm not putting that press on him right now.
Okay, I remove no press, but Jake, we need you with us. That's all I got to say.
Quite right. Okay, Professor Bill, you're up.
Okay. I'm still thinking about Jake. I mean, the 2-month doubling time is fast, but for those of us who have experienced doubling times of 2 weeks, I think it means that you're on enzalutamide now, Jake? Jake, are you there?
Yes, I had muted. Sorry, I muted myself.
You're being treated with enzalutamide now?
Yes.
Yeah, I mean, I think that even a 2-month doubling time means that you're getting some benefit out of the drug.
Correct.
And I really do appreciate the argument that it's best to get as much out of individual treatments as you can before you move on. I mean, I also understand what these guys are saying too, and they're, 2 months is a lot faster than 7 months. And I'm not sure what I would do in your case, but in any case, I do, to some extent, appreciate the argument that your oncologist is making. So, okay, so I'm.
Thanks, Bill.
For those of you, I haven't unfortunately participated in the call in quite a while. So let me just remind you that until last spring, I was being treated at Roswell Park Cancer Institute, which is my home institution in Buffalo, and where I've worked for the last 26 years as a cancer scientist. And beginning in the spring, I entered a clinical trial at Dana-Farber, testing a drug that inhibits a protein called ATR, and together with olaparib, which is a PARP inhibitor. And I had been on a PARP inhibitor alone for a couple of years and gotten an enormous benefit from it before it stopped working. And it became clear towards the end of the summer that the ATR inhibitor was not working particularly well. It was having a significant effect on visceral lesions and on my lungs and liver, but not on bone metastases. And my PSA was rising. So, and in addition, every cycle of the trial, I was running into problems with myelosuppression. My blood counts were bottoming out to dangerous levels. So I had to pull out of the trial in September. And both my oncologist at Dana-Farber and my oncologist at Roswell Park recommended that it was time for cytotoxic chemotherapy, and specifically docetaxel. And so I began docetaxel treatment at the beginning of October, I think October 10th. And so these are infusions that occur every 3 weeks. I tolerated the first infusion really well. In fact, I went home hungrier than when before I had the infusion, which was a surprise because I expected to be at least somewhat nauseous. But it turns out that the steroid that they administer along with the docetaxel can make you ravenously hungry, as Thibault understands. I just learned this from an email exchange with him. So, but the good news was that that first cycle knocked my PSA from about 158 down to 52. And that's an extraordinarily good response. It's probably in the top 5 to 10% of responses. And we don't know why, although because there haven't been very many studies to address that question. But I have been doing some literature research, and I think that the reason why probably has something to do with the mutation in the BRCA2 gene that caused my prostate cancer. In the breast cancer literature, there's clear evidence that patients with BRCA mutations respond much more robustly to docetaxel therapy than those that don't have mutations. The few studies in prostate cancer show mixed results, but I strongly suspect that that's the reason why. So, of course, this was really good news. It means that my prognosis for survival is significantly better than it was before I started the treatment with docetaxel. Instead of being, perhaps 12 to 15 months, it's now probably everything else held constant around 30 to 36 months, according to the literature. And I have done a pretty good job of finding treatments that string me along. So I expect that I'm going to be able to hang on for even longer than that. And in the meantime, I'm tolerating the treatment pretty well. It was tougher after the second infusion, and I've been told that it's going to get tougher with each round, that the side effects are cumulative. That means that I just feel pretty shitty for a couple of days after the infusion. The only other side effect has been that if anybody who has ever seen me knows, I had a very, very full head of hair, and not anymore. It's falling out quickly. And so my daughter has bought me a hat to wear and is preparing to shave my head in a couple of days because it's beginning to look pretty ugly. So I think that's it for me. If anybody has any questions, I'd be happy to answer them. But the take-home message here is that docetaxel seems to be working really well for me.
So, Bill, was the 52 after the second infusion or the first infusion?
That was on the day of the second infusion.
On the day of the second infusion.
Yeah, so that was the effect of one round of therapy.
Okay. And so you haven't tested since then?
No.
Okay. And when do you go in for the next infusion?
On the 26th of November.
Okay. For those of you who don't know Bill, he would have given the Beatles a good run for their money at the ripe old age of 65 now, Bill? 66.
Yeah.
66. So, but as I have told Bill, there's a good chance his hair will come back curly, so he'll finish up with an afro. So we'll see.
I'm looking forward to
it. Okay. Bill, we're all thrilled, I think I can say this, that you're responding so well to the docetaxel. What you left out that I'm aware of is that the plan is to do 4 infusions and then to go into another trial that Bill's identified with his GU Med-Onc at Dana-Farber. So, come the new year, hopefully we'll see Bill in another trial.
Yeah, although that's changed a little bit, Rick.
Okay.
After when I told Atish Chowdhury, my oncologist at Dana-Farber, about the PSA result, he recommended that we continue for another couple cycles beyond 4.
Okay.
Before we stop.
Okay.
Yeah, so depending on how I'm tolerating it, that probably will be the case. But in any case, that's just another 6 weeks, and my plan is to look at carefully at a trial that he's participating in that involves drugs that target a protein called CHEK1, which functions just upstream of ATR. Okay. And both these proteins actually work in a genetic pathway that my laboratory discovered about 15 years ago. So I think it's remarkable. Taking another shot at that pathway, but that probably will be the trial that I go into when I'm finished with docetaxel.
Bill, when do you think you might have the results back of the sequencing from the lymph nodes?
Atish called me a couple of days ago to tell me that this is the second time. So I should just quickly explain that I also am participating in a clinical trial at Dana-Farber that involved a lymph node biopsy, which I had about 3 weeks ago, and 2 or 3 weeks ago. And the goal here is to recover enough tumor DNA to sequence the tumor cell exome, meaning all the genes in the tumor. And we'll also learn things about whether or not I have microsatellite instability, in addition to a few other things. And so I lost my train of thought here, Rick. What was I going to tell you?
You were telling us that Chowdhury called you a couple of days ago?
Oh, yeah, to tell me that this time, unlike the biopsy that I went through last spring, there was plenty of tumor.
Great.
Plenty of tumor cells in the biopsy. So we're guaranteed to get some DNA sequencing results. And it probably will be another 2 weeks before I learn what those are.
Okay. Don't let them string you out, because they do that with this bloody dream team biopsy. So stay on them.
Yeah, but I got all these guys when I go to Dana-Farber,
Yeah.
all the scientists who are involved in this trial come and hang out with me. So they're all on my side. They're going to be pushing for it.
Okay. All right. Well, we know they're all part of your fan club, but the problem is they send these out. They send that biopsy out. I think it goes to Michigan. I know on the West Coast it goes to OHSU. On the East Coast, I think it goes to Michigan. And, we're going to have to cart you over to Ann Arbor, and you're going to have to wow them there as well. I just don't want it getting caught up, as I've seen it happen with these Dream Team biopsies.
But the sequencing in this case will be done at Dana-Farber.
Oh, is it? Okay.
Yeah, and they have their own oncopanel of genes that they normally use for these biopsies, and in a few cases they do, complete exome sequencing.
Well, I'm not certain, but I would ask the question whether they're talking about their own Dana-Farber panel, because I know UCSF has their UCSF 500 too. But
yeah,
I think that's the Dream Team. I think that's the Dream Team biopsy, yeah. and I think they centralize, because the research you're doing, my guess, is part of Dream Team East, and they centralize those biopsies, but I'm not certain about that. So I hope you're right and I'm wrong.
I will keep on top of it and make sure.
Okay. Ask Chowdhury, ask your buddy Atish whether this is in-house or whether this is part of the Dream Team biopsy panel.
Yeah. Okay. Will do.
Okay. All right. We're going to keep moving because we're running out of time, and we've still got a couple of people to check in with. So I still want to check in.
Quick question for Bill.
Oh yes, sorry.
I just wanted to know if Bill, are you following some sort of fasting protocol with the docetaxel?
Oh, thank you. Thank you for raising
thanks,
that.
Len. No, I haven't been, and it's only because I stupidly forgot. But something reminded me. So this is, as some of you guys know, this is an issue that I was involved in directly with the studies that showed that this might be a good approach. And I just totally forgot, Len. So I will be fasting before the next infusion on the 26th.
Okay, continued good luck with that.
Yeah, and Bill, because we'll probably run a little bit over, but this is really worthwhile for the guys. Just explain to the guys, if you can, in the dumb down as much as you can for the dummies that we are on this call, why the fasting is thought to be important before chemo.
So the fasting. The withdrawing nutrients, and particularly nutrients such as glucose, which is produced by the breakdown of carbohydrates, will drive dividing cells, such as those that are in your intestinal epithelium, hair follicle cells. Most of the cells in your body are not normally dividing, but these are the ones that are, and they're the ones that cause problems with chemotherapy because they are dividing, and which means that they're sensitive to chemotherapy, and that causes all the side effects like nausea and hair loss. So the withdrawing nutrients will drive those cells temporarily into a quiescent state where they're not replicating their genomes, and therefore are somewhat protected from the effects of chemotherapy. So doing so, a short-term fast for a couple of days before a chemotherapy infusion can lessen the side effects of cytotoxic chemotherapy. And although this isn't going to be the case for me because I don't want to go up on the dose of the drug, but it does, since it does reduce the side effects, it opens the door to the possibility of increasing the dose without causing, severe problems with side effects. That's not something that we'll be doing, but it's something that others do.
Right. And your former colleague, Walter Longo, has some sort of a diet regime where he has put together some food types that he suggests can mimic the effect of dieting whilst you're still eating. Is that?
I can tell you, Rick, that I know nothing about that, and I don't want to know about it. I have
Okay.
respect for this fellow, and I have, just from that point of view, I wonder whether or not the diet that he sells really works. I mean, it sounds to me like this is a money-making venture. But having said that, I don't have any evidence for that, and I am biased. I really had a difficult relationship as.
Yeah, I know. I know. Well, listen, the good news is your chemo's on the 26th and Thanksgiving is on the 22nd. So you can stuff your face on the Thursday, the Friday, and the Saturday, and that, or certainly the Thursday and the Friday. And then you'll just have to go easy on the cold turkey sandwiches, Bill.
Right. Yeah, exactly. I'm looking forward to it. It'll be great.
Okay.
And I hope everyone else has a wonderful Thanksgiving too.
Thank you. Thank you. Anybody else want to say anything to Bill before we move on to Shref and to Les?
I just want to. This is Jake, Bill. I just want to say I'm really happy to hear that the first dose really did you well, knocking your PSA down so well. I hope it continues to do that. I'm sitting here thinking, if you're famished after your first dose of Taxol dose, I can only imagine how you're going to feel after fasting for 2 days.
You're right. Yeah. Yeah.
And I do have a question. You continue with Lupron, right, when you're on chemo?
Yes. Yeah,
Okay.
I've been on, and it's not Lupron. It's the Eligard.
Okay, ADT. Yeah.
Leuprolide.
Yeah, I always say Lupron, but it's just ADT. And then my final question is, what did they biopsy this last time?
A retroperitoneal lymph node in my back, which was quite an experience. I mean, it's very high tech. They do the biopsy while I'm in a CT scanner in the operating room. And, so they get a real-time image, but that was where it was. It was also very painful because I badly injured my back a couple of weeks ago. I think Rick has told you guys about this.
Yeah, we heard about that.
Yeah, and what did you call it, Rick? Something like
endurance gardening.
Endurance gardening, right? Yeah.
All right, listen, we must move on. Let me first touch base with Les. Les, you're home from Rochester. Was this treatment successful? Do we know anything?
No, we don't know much of anything yet. The only thing I can say is that the side effects were very minimal. We'll just have to wait and see what the results are. That's about it.
And when are those results going to start coming through? How are they going to come through? Is this it'll be PSA testing that we'll start seeing soon?
Well, they haven't told me yet, but I'm supposed to go back up to the Mayo the end of February. They may do another P11 or C11 PET scan, choline PET scan.
Okay. So, how are you feeling in yourself?
Feeling fine. It's pretty much the same as what I had been. I'm on Lupron, so I'm don't have much endurance, but otherwise feeling about the same as I had been.
Are you walking? Are you getting out there and walking every day?
Trying to.
Okay, just checking. So, okay, and when do you think you'll do the first PSA?
I don't know. I'm going to do that on my own. They haven't scheduled anything at Mayo, but I've been doing that on my own locally.
Mm-hmm. Okay.
So I'll probably wait a few more weeks and then have it done again.
Okay. Okay. All right. Well, our thoughts are with you. I'm glad that you didn't suffer any side effects. As you know, Peter is right in the middle now. Or I shouldn't say he's at the beginning. I think he started at the this week with his, or the end of last week with his PBRT with Dr. Rossi in San Diego.
Right.
And we haven't. He's not on tonight, so we don't know how he's doing. But I know that you and he are in touch with each other, so so we're thinking about you, and I'm glad that that you came out on the other side feeling as good as when you went in.
Right. Thanks.
Anybody want to talk to? Anybody want to ask Les anything about PBRT?
Les, you had the same lymph node involvement that Peter had in the abdominal area?
I wouldn't say that it's identical. I don't really know, but mine is in that same general area anyway.
North of the pelvis.
Yes, right. It's as far as I know, it's close to the spine.
Right.
Okay.
And it involved 20 plus sessions as well. So
yes, yeah, 25.
right. Okay. We'll move on because we're sort of just over time, so we have a little bit to go. I'm using a little bit of your grace. Treff, we haven't heard from you for a while. Tell us what's going on there.
Well, it looks like we may get some radiation treatment. MIRT on the prostate and the pelvic bed, and some SBRT on the bone mets on the pubis ramus.
Okay.
Or
So
continue on to ADT.
Just remind the guys of your original diagnosis and what you've done.
About a year ago, I was diagnosed with a double 9 Gleason and metastatic disease with a 2 to 3 centimeter mets on my pubis ramus. Started on ADT2, which would be the Lupron, abiraterone, and prednisone. Responded well to those drugs. But from listening to this call, I realized that even though it was metastatic prostate cancer, it was ogliometastatic. So chase that down, and I believe we're going to get some radiation treatment. And when I talked to the oncology guy over at Cleveland Clinic, he talked about a cure possibility. I haven't heard that since the diagnosis.
Mm-hmm. Who is it that you were speaking to at Cleveland Clinic?
Garcia.
George Garcia was the medical oncologist, and Dr. Meehan, who was trained at Johns Hopkins, was the radiation oncologist.
Okay. Because I'm working with a fellow that lives in Cleveland who used to be on the board of is it Seidman in Cleveland? I forget the name of the clinic in Cleveland, the cancer clinic. And he's familiar with Cleveland, and then he's also he's working with a fellow at the hospital there who he thinks is very good, who's an up and coming star. I can send you his name. Dan, his last name has just gone from my mind. It begins with an R. I'll look it up in a second. Are they talking about radiating your prostate as well? What's called
Yes.
debulking it?
Yeah, I think 4 or 5 weeks, 5 days a week for the prostate and pelvic bed. And that's with the IMRT.
Right.
And then SBRT on the Mets.
So, I mean, one of the questions I think I would be wanting to ask them is if they're going to radiate the prostate, why they can't use the SBRT for the prostate as well. It's harder to use it for the pelvic girdle, but they could use SBRT and then it would reduce the number of sessions you needed.
Well, he explained to us that because I've got it in one of the seminal vesicles and have a good chance of having it in the and it's pushed the boundary of the prostate in the scans, that the slow dose radiation would have more of an impact overall, where the SBRT has a very strict cutoff.
Right. Okay.
A sharp margin. So he felt that the 5 or 6 weeks of treatments would put more radiation into and catch hopefully all the cancer in the around the prostate and the
Okay. I mean, it sounds it sounds like an aggressive and a good plan, Shreff. And I for one am really pleased that you're taking these steps. Is the fact that you're going to just sort of settling on this plan, is it making you feel more comfortable, less anxious? Is your state of mind better?
Oh, I'm still pretty anxious. Just we don't have anything scheduled. Trying to get, we have to be over to Cleveland. I'm about 3 hours away for 4 or 5, 6 weeks, about a week to get the program set up, and there 5 or 6 weeks of treatments. Just getting all that put together. Okay.
Let me throw it out. Len, first of all, Len, do you want to talk to, or do you have any thoughts to share with Shreff?
I don't think I could add anything to what you've already talked about, Rick.
Okay. And anyone else, Jake? Did we lose Jake? Oh, no, he's there.
I'm still here, Rick.
Yeah,
I stepped away for a minute or two. What was the question?
I just wanted to know if you wanted to say anything to Shreff.
Oh, I'm glad to see you again, Shreff. It's been a while. We miss you on the inner conversations. I'm glad you're doing okay. Hope you continue to do so.
Thank you, Jake.
Would anybody else like to talk? I mean, this whole idea of debulking and radiating the bed is something that's gathering speed. Ken Anderson did it. Ken just came back yesterday from Australia. That's probably why he's probably still standing on his head, which is why he isn't with us today. But Ken did it after chemo. Dr. Steve did it after chemo. We know, as I don't think you were on at the beginning of the call, Shreff, but Carl Foreman was diagnosed with metastatic, and he's going in for surgery tomorrow. So, we're moving closer to the other cancers where we combine, when you have metastatic disease, we combine it with much more aggressive primary treatment, or treatment on the primary lesion, I should say, not primary treatment, but treatment on the primary lesion. So, you know, there's more and more evidence that it makes sense to debulk. Is there anyone else that would like to talk to or say anything to Shref? Okay, well, Shref, don't be a stranger with us. Stay.
Hey, Rick, I wanted to make sure that you know, the first time I was on the call and I gave my statistics, you said that one bone mets was a special thing. And it took me a year to battle that out and get somewhere with the ogliometastatic disease.
Yeah.
So I really got some big help from you.
Well, we want to keep giving thank you, and we want to keep giving you some big help, but we can only do it when we talk to you. So so come on the call, come talk to us. You can drop off. If I see you, I'll make sure I get to you quickly, because you know you flit in and you flit out.
Yeah, where you live out in the country, our internet is terrible.
Okay. Well, you can always call in. You can use the phone, or are you going to tell me you don't have good cell phone service there?
No, we don't have good cell phone. I was expecting to drop you anytime. You're on a cell phone now.
Oh, do you have a landline?
We do have a landline.
Okay, you can use the landline.
We don't have long distance.
Okay. All right. Well, yeah, we're gonna have to figure out how to get you long distance. I don't know, but anyway, we want to talk to you. We want to support you, especially whilst you're going through this, and there are other guys that have done it. So that's basically what I have to say. Guys, thank you for bearing with us. We ran about 10 minutes over today, but it was a very good session. We covered a lot of stuff. And thank you, Willie, for bearing with us. And hope you gather in information slowly. You got an idea how we run these calls. Peter's calls are similar. They're just not quite as detailed in all the different things that are going on. We will meet next week on Monday, so I don't have to wish you all happy Thanksgiving now. I can wish it to you on the 19th. And that's it for now. I'll say good night. This will get posted. Hopefully, if you want to listen again, it'll be posted probably tomorrow morning sometime.
Okay.
Good night, everybody.
Good night, everybody.
Good night. Good night. Good night.
Thanks, Rick. Thanks, Len.